Hi everyone, thank you for joining tonight on a Wednesday evening. I hope you all are okay. My name's Adan. I am currently an SFP doctor training in Stoke, which is up north in the Midlands. And today I'm going to do a quick kind of finals oriented tutorial on lower GI surgery. I'm not sure if any of you have come for the previous session, which was in breast surgery. It'll be in a similar format today as well. Hopefully it'll last an hour, and we'll cover a few kind of SBA questions, and we'll crack on. Before that, I'd just like to say hi as well to those streaming online from the Bite Medicine platform. So it's a question bank, in case any of you are new to it. It's a question bank with a lot of SBAs and cases as well, which cover kind of all the specialties you need to know for medical school. And there'll be explanations as well and good key points. I found it quite helpful as well using it through medical school. And there's also an online textbook where creators have summarized the most important conditions, high yield conditions in medical school. And they've given a very detailed explanation for all of it. So today we'll be covering some common lower GI conditions, such as cancers, GI cancers, bowel obstruction, hemorrhoids, appendicitis. It'll be very finals based, and the context will be in UK. I'm not sure if any one of you are international, but we're going to focus on England. I'll be touching on some subjects later about the screening program in England as well. For bowel cancer. So if any one of you have any questions, feel free to pop along in the chat and I'll answer them as I go along. Before we start, I'd like to invite all of you to join the Menti kind of question answering session on menti.com. So if you use your phones, go to menti.com and fill in this code 56310363, then you'll be able to participate in the SBAs as we go along, which I think would be immensely useful for yourselves if any of you are in midst of preparing for exams, as well as we can get feedback and discussion as we go along. Just give you a few minutes to join. If that's all right, then we will make a start. So we'll cover some SBA questions today, and in the next round, we'll have a quick round of spot diagnoses, referring patients, something to really train your reflexes as a doctor, to pick up red flags, and also if this patient's suitable for referral. So we'll start with the first SBA. The history is a 76-year-old lady presenting to the ED with a sudden onset severe abdominal pain, and she's also complaining of some occasional blood-tinged diarrhea. She's got a past medical history of atrial fibrillation, has had an ischemic stroke 3 years ago, and has asthma. She's got no drug allergies. So which of the following investigation results would correspond to the most likely diagnosis in this stem? I will start the Menti quiz. In the meantime, you can all have a think. Oh. So the options are having a leukopenia on the full blood count, having an anemia on urea and electrolytes, having a raised lactate on a VBG, or having metabolic alkalosis on a VBG, or would you see a cecal volvulus, an abdominal X-ray? So I think a lot of you have answered. Well done, keep the responses going. It's really good to kind of practice. Don't worry if you're going to get it wrong. You're here to learn. Yeah, so there's quite some variation. Everyone's answered kind of each of the options have been answered. But the majority is correct. So the correct answer is having a raised lactate. If we go back to the stem, I think the first question we have to answer in this question is what is the most likely diagnosis? And I think with this history, with the cardiac history, with sudden onset severe abdominal pain, and also blood tinged diarrhea, it would be compatible with the diagnosis of mesenteric ischemia, which is acute. So this would be the most likely diagnosis here. With it being a ischemic condition, we would usually see a raised lactate in ischemic conditions, and that explains why the VBG would show a raised lactate in this condition. A leukopenia wouldn't be seen in cases of ischemia, rather a leukocytosis, so you would see a high kind of white cell count. Anemia doesn't show on U's, it would be shown on a full blood count. The fourth option, you wouldn't really see metabolic alkalosis. You would be able to see an acidosis more because of the lactate kind of raising the number of acids in the blood. And this is not exactly a cecal volvulus, so you wouldn't, it's not likely to be a cecal volvulus, so you wouldn't really see that. You wouldn't be expecting to see that on an abdominal X-ray. So well done to those of you who got it correct. I'm just going to quickly run through the basics of acute mesenteric ischemia, which is a surgical emergency and something final year med students should all kind of aim to be able to recognize. So the pathophysiology is when there's an ischemia affecting the SMA, the superior mesenteric artery, which supplies the midgut, which is the distal part of the duodenum towards the 2/3 of the transverse colon. That would be classified as mesenteric ischemia. So it's the ischemia of the small bowel. It's not ischemic colitis, which is ischemia of the large bowel. So that's the difference. It's most commonly arterial as well. And I'll quickly run through the clinical features. I think the most important one would be severe kind of out of proportion abdominal pain. So the patient, when you look at them from the bedside, you'd be able to see them screaming in pain. But when you examine them, it feels like the abdominal pain isn't kind of exactly in proportion of how much pain they look like they're in. So that's kind of a classic sign of mesenteric ischemia that you guys should be aware of. Also nausea and vomiting, which is kind of expected because there's something in the gut and it's irritating, and diarrhea as well as rectal bleeding occasionally. So the management for this emergency would be drip and suck. By drip meaning you give IV fluids, and suck by inserting a nasogastric tube to kind of decompress in some sense, like take out the fluids so it doesn't cause any more harm, and also IV antibiotics. So often you would probably approach the patient in an A2E assessment because that a patient with mesenteric ischemia is most likely to be acutely unwell. Is that okay? So someone's asked, how does mesenteric ischemia caused blood-tinged diarrhea? I'm not exactly sure of the exact mechanism, but I can tell you that when a blood vessel gets blocked, that can affect kind of how the gut works, and that can cause blood-tinged diarrhea. It's not a common sign, but it's kind of there for you to remember. If you like to kind of read up a bit more about it, I would direct you to the White Medicine textbook. Someone's asked why you need to give antibiotics in mesenteric ischemia. So that's a really good question. And I think it would be sensible to ask as well if it's reasonable to give antibiotics in an MI, because mesenteric ischemia is kind of similar. I would say the reason is being the gut having a rich kind of microbiome. It would not be, I think it would make an individual susceptible to infection if that blood supply to the gut were to be cut off, and it would make it easier for the kind of the gut microbiome to cause an infection, if that makes sense. Why do you give IV antibiotics? Yeah, I mean that's a good point. An IV access is also always preferred because it kind of protects the circulation, which is usually what needs to be protected and what's going to stop the patient from becoming septic. If you give an oral antibiotic, it could be questionably useful, I guess, but I think in an acutely unwell patient with kind of unstable observations, we would be thinking of sepsis as well, and IV antibiotics would probably be your go-to. I hope that makes sense and answers your questions. Is that all right? Well done, everyone. If that's okay, then we'll move on to the next question. Yeah, I think the most important thing to bear in mind is also referring to the surgeons, the general surgeons, which can do something, make a definitive kind of management to decide whether or not they want to definitively manage this case. Right, so we move on to the next SBA. So it's a 69-year-old man who's seen in clinic with a 4-month history of a change in bowel habit with intermittent bloody stools. He suffers with fecal incontinence as a result. So he undergoes a CT scan because it's suspicious, and they find a rectal tumor that involves the sphincter complex, the anal sphincter. He's got no other past medical history and he's fit for surgery. So which of the following options are appropriate management for this patient? I'll start the Menti quiz. So would it be Hartmann's procedure? Would it be an anterior resection? Would it be a pan-proctocolectomy? Would it be a left total colectomy or an AP resection? Couple minutes for everyone to answer. Okay, so I think the responses have halted a bit. Well done to those who attempted. The correct answer would be AP resection. So I think I'll move on to the next slide where it gives us a quite kind of nice overview of the different procedures in colorectal cancer. So there's colectomies, which involve removal of the colon. There's left hemicolectomy, which involves removal of the left colon, and then right extended colectomies, sigmoid colectomies, subtotals, and totals, as we can see here. There's also anterior resections, which involve removal of the sigmoid and the rectum, but it doesn't remove the anus. So in cancers like this case that we've discussed, it would be worthwhile doing an AP resection, an abdominal perineal resection, which also removes the cancerous area, which is what we'd like here. Yeah, so there's high anterior resection, there's low anterior resection as well. High kind of removes up to the rectum, but low removes kind of the part of the anus as well, but it preserves the sphincter. Whilst the AP resections removes the whole chunk of the anus and the rectum, and a bit of the sigmoid as well. Is that all right? Does that make sense? The majority of you answering got kind of anterior. Yeah, we were a bit kind of in between anterior sections, pan-proctocolectomy, and AP resections, really. So as long as you guys are happy with that explanation. So pan-proctocolectomy is not suitable because we want to preserve as much tissues as we can without removing too much. So in this case, AP resections would be better because it removes the cancerous tissues and gives a nice kind of margin, which is the sigmoid and the rectum, for the cancer, but also kind of preserves as much of the patient's bowel as possible. Any questions? If not, then I'm happy to move on. Yep. So we'll move on to the third SBA. So the case is about an 18-year-old man who presents to the emergency department with right-sided abdominal pain. He's got nausea and he's got anorexia for the past 2 days. He's also been feeling nauseous. He's got a past medical history of asthma. So you kind of palpate the patient's abdomen, you examine him, and you can find that he's maximally tender of the McBurney's point. So the question is, what is the anatomical location of McBurney's point? So here are the options. I will start the Menti quiz. It's quite word for this question, so I'll give you guys a couple of minutes to kind of have a read in detail. think everyone who wants to have a go has had a go. So I think the key to these questions is really kind of paying attention to every word, because it's common in exams where they use it to kind of trip you up, and hopefully some candidates will fall for it. But if we kind of read every word in detail, then hopefully we'll be able to prevent that as well. So the correct answer is 2/3 of the distance from the umbilicus, which is your belly button, to the right ASIS, which is kind of the bumpy crest you can feel on your hip, anterior of your hip. So the other options are significant landmarks, but they're for other stuff. So the pubic tube, I'll start with the pubic symphysis, which is kind of in the middle of in the midline, in your pubis, between your two pubis bones. The pubic tubercles are lateral to the pubic symphysis, and is worthy kind of revising, I feel like, for this question about the landmarks for inguinal canals as well. We'll talk about that in a later lecture. So I wanted to kind of talk about what this man's most likely diagnosis is, really something high up for exams. So he's probably got appendicitis, which is an acute inflammation and infection of the appendix. It's usually caused by fecalith, which is a hard mass of stool mixed with lymph nodes, dead kind of white cells, debris, and a lot of other kind of stuff that you can find in the body. So there are certain clinical features to be aware of. There's a lot of eponyms, and a surgeon that I spoke to once said that one of the most kind of specific features for appendicitis is anorexia. So a patient with appendicitis wouldn't really have an appetite, or if you offer them food, they'll probably say, no, I'm not interested. So some of the classic signs would be migrating pain. Usually it starts with generalized pain, because that affects the inner layer of your peritoneum, and then it kind of affects the parietal layer of your peritoneum, which gives you more specific pain sense, which is why that it migrates to the right lower quadrant of your tummy. And you get loss of appetite as well. And you can also get kind of tenderness over the McBurney's point, which is what this man experienced in this case. You can also get Rossing sign, which is when you press on the left iliac fossa, you get some pain in the right iliac fossa. The psoas sign, pain is worsened when you extend the hip, when you lie the patient flat and you tell them to straighten the hip. The obturator sign, the pain is worsened by flexing and internally rotating the hip. So I think some of the signs to really bear in mind. This is quite OSCE kind of style question, I guess. Something to bear in mind, really. And there's lots more, something to read about in your own time that I will be having time to cover today. So the most kind of common investigation for appendicitis would be a CT abdo-pelvis with contrast, which is what is usually done, standard practice on surgical wards. And so acutely, this patient would be acutely unwell as well. So you would want to stabilize them with an A to E assessment by giving them fluids, analgesia, and antiemetics, make nail bite marks for surgery, and antibiotics, which is disputable whether or not giving it is useful. There's lots of articles out there as well. I'd say just keep that in mind as well, the concept. Definitively, you would take out the appendix the inflamed, infected appendix by speaking to the general surgeons. So straightforward case, appendicitis. If anyone's got any questions, feel free to pop in the chat. If not, I will move on to the next SBA. No questions? If anyone isn't like trying to type, feel free to ask them kind of at the end of the talk. I will address them later. Right, so let's move on to the fourth SBA without further ado. So this case is about a 59-year-old woman presenting to the ED complaining of some colicky generalized abdominal pain and bloating. This was associated with a 3-day history of abdominal discomfort and 2 episodes of vomiting, which was bilious in nature. So she's had a hysterectomy about 2 years ago for a large kind of fibroid, and her last bowel movement was 2 days ago. You examine her tummy, you can find that it's soft, but it's a bit tender in the umbilical region without any guarding. The bowel sounds that you've heard were tinkling in nature, and her vital signs are stable, which is the most likely diagnosis. I will start the Menti quiz now. So could it be large bowel obstruction, a perforated bowel, small bowel obstruction, an anastomotic leak, or a formation of rectal vaginal fistula? So I'll give you guys a couple of minutes to answer. Well done to those of you who are participating. Right, I think we've had all the answers. I think everyone's gone for small bowel obstruction, which is absolutely the correct answer. It's a very common kind of, rather common compared to large bowel obstruction, and it's most likely caused by adhesions, which we can see that in this lady, she's had previous abdominal surgery, and she's at risk of developing these adhesions over years and months. So that's why it could be small bowel obstruction. I actually saw this case in one of my GP placements, in which we promptly referred her to see to go to the SAU in the nearest hospital. Yes, I'll briefly talk about the other options. Large bowel obstruction is less common and it's more sinister. And in this case, you would not be kind of expecting bilious vomiting with large bowel obstruction. It would classically be feculent vomiting. Perforated bowel is a possibility, but kind of patients usually are more unwell with very kind of peritonitic abdomen that's guarding, and yeah, it would usually occur post-op, and so does anastomotic leaks, and yeah, a patient who would be septic. So perforated bowel and anastomotic leaks would be possible, but less likely in this case. A formation of a rectal vaginal fistula. It wouldn't present this way. A rectal vaginal fistula is a connection between the rectum and the vagina, so you would expect some kind of fecal incontinence, with the kind of the fecal matter coming out of the vagina through the fistula. So exactly present like that. So again, I'll briefly talk about kind of small bowel obstruction. So in bowel obstruction, there's usually a point obstruction. So you can see very clearly that a single point in the bowel is obstructed, and everything kind of distal to that is fine. So it causes kind of proximal bowel to dilate, proximal to the obstruction point, and mucosal edema, and it can cause third spacing of fluid, so patients can become unwell. So some of the causes are adhesions, hernias, Crohn's disease, IBD, volvulus, clinical features, abdominal pain, vomiting, nausea, distension, tenderness, kind of all the classic shebang in an acute abdomen. But I think what's most kind of important in distinguishing small bowel obstruction is the background of the patient. One of the most important risk factors would be definitely if they've had previous abdominal surgery, which is a common cause of adhesions causing bowel obstruction, and also hernias as well, if they've got a previous history of that. So something to bear in mind always is kind of on what context patients present. Would give you a lot of clue in finding out the diagnosis. And also, tinkling and absent bowel sounds. That's a classic sign of bowel obstruction to bear in mind. If you do a PR on them, you would see it empty because the rectum is kind of most likely distal to the point of obstruction. It can be blood tinged as well with strangulated hernias. And they can become quite unwell, becoming hemodynamically unstable because of the third spacing of fluid, as I've talked about before. Oh, I'll check if anyone has any questions. Oh, the quiz code. Yes. Let me copy it and send it on the chat. Yep, so that's the quiz code. I've just sent it through on the chat. Third spacing of fluid. We've got a question asking about what the third spacing of fluid means. So it means kind of this fluid going into your extracellular kind of space, because we can broadly speaking, kind of fluid in your body is in three main compartments, which is your vasculature, which is in your blood vessels, in your intracellularly and extracellularly. So in kind of small bowel obstruction, you get that mucosal edema because of the obstruction, and that causes fluid to kind of be stuck in extracellularly. So that wouldn't be in the vasculature. So the fluid in the vasculature would go into the intracellular fluid. So that causes kind of third spacing of fluid. Sorry, extracellular fluid. That causes third spacing, and patients can seem to be hydrated, but in fact there's not much fluid in the vasculature itself. I think that's the main point to note. So that's why we would be needing to give them fluids. I hope that answers your question. Yep. Any further questions? If not, then we can move on to the next SBA. Running a bit short of time, so I'm going to hurry up a little bit. So the fifth SBA, we're on our second last penultimate SBA. We've got a 40-year-old man presenting to his GP with painless rectal bleeding. He's got past medical. He's been diagnosed with hemorrhoids. He was given analgesia and Usol. but it hasn't kind of improved today. So he's come back today kind of complaining that anisole has had limited effect. He's got no drug allergies or past medical history or surgical history. So you perform a DRE on him and you can find an external hemorrhoid at the 3 o'clock position, which is pink and non-tender. So what would be the most appropriate next step? I will start the Menti slides. Sorry, Menti questions. Would you refer this man for a 2-week wait suspected cancer pathway? Would you arrange urgent admission to hospital? Or would you prescribe him a course of antibiotics? Would you refer him for injection sclerotherapy or refer him for band ligation? Give you a couple minutes to attempt. I've just sent the Menti code on the chat as well if anyone else wants to join. Okay. Thank you for those who attempted. It seems like there's quite a few of you have chosen referring him for a 2-week wait suspected cancer pathway. So it's a good thought. I can tell you guys will be quite safe doctors, because if you refer him anyway, there won't be any harm. But I'm guessing that in the NICE guidelines, it states that men over 50 should be referred, and for unexplained rectal bleeding as well. We've examined him, we found a hemorrhoid, which is most likely the cause of his rectal bleeding. So I would kind of hesitate a little bit to say that it was unexplained. So he's got kind of hemorrhoids. So this patient has hemorrhoids refractory to kind of conservative management. So overall, you would want to consider referring him for band ligation, which is the current kind of best second-line treatment, surgical management, non-surgical management for hemorrhoids. Whilst you would consider injection sclerotherapy, which is kind of, I'll move on to that in a bit. So injection sclerotherapy is basically injecting kind of oil into the hemorrhoid to cause it to die, and then it will just die off on its own. But compared to rubber band ligation, it causes a bit more harm and has an increased recurrence rate. It takes longer as well. So the current kind of best treatment would be rubber band ligation for hemorrhoids. So I'll briefly talk about how we manage hemorrhoids. So first line, as this man has already been through, would be conservative, where we try and prevent constipation, which hemorrhoids are most likely caused by kind of that straining. So we want to ensure that they've got adequate fluid intake and good dietary fiber intake. We also want some anal hygiene techniques as well. So some of the other second line management options would be rubber band ligation, as we've talked about, kind of the best current second line treatment. So we tie a band around the hemorrhoid to strangle it, and it will die off on itself. Injection sclerotherapy, photocoagulation, diathermy are also other options, but they're usually used when rubber band ligation is not suitable. Some more surgical kind of management would be for large and hemorrhoids refractory to the above techniques. So you would do an excision, you can do a hemorrhoidectomy, an excision, you can do a staple, putting staples to remove kind of anal mucosa, and you can also ligate arteries to stop kind of hemorrhoids from getting worse by fixing them to the anal wall. I won't go too much into detail because I don't think we need to know too much about these unless you're a specialist. But if there's any questions, let me know. Okay, I don't think anyone has any questions. So we'll move on to our final SBA, which is the top decile SBA. And then we'll move on to our next round of quick kind of fire questions. So I've got a top decile question. For those of you who are keen, a 25-year-old woman who's under the care of, who has got ovarian cancer. She's got a strong family history of cancer. She reports colorectal cancer, having in both her father and her grandfather in their 40s, and her maternal aunt was recently diagnosed with endometrial cancer. So the question is, which of the following is the most likely kind of hereditary condition that's running in this patient's family? Start the Menti quiz. Is it familial adenomatous polyposis? Is it VHL syndrome? Is it Lee-Fraumeni syndrome? Is it BRCA mutations? Or is it Lynch syndrome? Yeah, we've got a majority of you. I'll move on if that's okay. We're running a bit short of time, so I'm going to speed things up a little bit. So the correct answer is Lynch syndrome, which the majority of you have got, because it's there's a family history of colorectal cancer, which is early onset, and also endometrial cancer. The other kind of conditions, FAP is not linked to an increased risk of endometrial cancer. VHL doesn't typically involve colorectal or endometrial cancers. Lee-Fraumeni is quite rare, associated with other types of cancers like breast and bone. BRCA mutations are also not associated with colorectal cancers as strongly as breast and ovarian cancers. So I'd just like to quickly kind of cover the Lynch syndrome Amsterdam criteria for diagnosing families with HNPCC, which is also another name for Lynch syndrome. I'll talk about the full name in the next slide, but it's a 3-2-1 rule. So at least three relatives with confirmed colorectal cancer, at least 2 successive generations involved, and at least 1 cancers have to be diagnosed before the age of 50. There are additional caveats. One should be a first-degree relative of the other 2, of the ones affected, and FAP must be excluded. We'll talk about what that is in the next slide. So HNPCC is for hereditary non-polyposis colon cancer, or Lynch syndrome, which is more common and it is caused by mutations in DNA mismatch repair, which causes microsatellite instability. MSH2 and MLH1 are the genes that you want to remember. It doesn't cause a lot of polyps to form in the patient's bowels, so there's not a lot of kind of dots if you've seen polyps on an endoscopy. So it usually affects older patients, the right colon, and is associated with endometrial cancer. There's also kind of 50 to 80% chance of kind of the polyps turning malignant. Whereas compared to FAP, which is familial adenomatous polyposis, I can never pronounce that word right, but it's less common. FAP is less common. It's caused by a loss of function of a tumor suppressor gene, APC. The gene is called APC, and it causes formation of lots of polyps in a patient's bowel. It usually affects kind of younger patients and or the left colon. The polyps that's in patients with FAP almost always turn malignant. So patients usually have kind of a removal, quite a radical removal of their bowel in their 20s or 30s. So it's not the best kind of condition to have. Right. So does anyone have any questions with regards to genetics of colorectal cancer? No. If not, then we'll move on to a quick kind of rapid fire round, which I was hoping to train kind of everyone's reflexes in recognizing emergencies and red flags as well. So we'll start with a question on spot diagnoses. There's a case here. I want you guys to type in what the most likely diagnosis is on the Menti quiz, which has just started. So this case is about a 77-year-old gentleman who was brought in by an ambulance because of sudden onset severe abdominal pain. He's got a cardiac history. He's taking atorvastatin and amlodipine, no drug allergies. He's had a abdominal aortic aneurysm screening, which shows that his aorta was 4.5 centimeters in size. On examination, you can see that he's in a lot of pain. His abdomen, however, is soft and non-tender, and you can hear bowel sounds. You can't feel an expanding pulsation in his umbilical region. What is the most likely diagnosis here? So we've got some interesting responses. Just give a few minutes for people to have a think about. Right, so we've got kind of some interesting responses, but the diagnosis I was thinking here was acute mesenteric ischemia, which we've talked about at the very beginning. Remember what I said about kind of severe out of proportion abdominal pain, which is what we can see in this gentleman. So on bedside examination, you would see that he's kind of screaming, he's in so much pain. But when you examine him, you can feel that his abdomen is soft. So that's what we mean by kind of out of proportion abdomen pain. There's quite a significant amount of you that put ruptured AAA. Whilst that is a very important diagnosis to rule out, I agree with you. However, when we were examining the abdomen, we felt that there wasn't a pulsation, and his symptoms are better explained by another emergency that we've covered, which is mesenteric ischemia. So I think whilst this is an important diagnosis to rule out, and in real life you would probably do a CT abdo-pelvis, which would show that anyways. I think the most likely diagnosis here would be mesenteric ischemia, given the abdo pain, the severity of it. That makes sense. So without further ado, we'll move on to the next kind of set of questions. So the next set would be determining whether or not a patient should be referred on the 2-week wait suspected colorectal cancer pathway. So first case, I'll start the Menti quiz. So this is a 55-year-old male. Presents to the GP for a routine review. He's got OA in the knees bilaterally, and he's reported kind of being a bit more constipated for around 2 months. He's not got any rectal bleeding, has not lost any weight, but however, he's recently switched jobs from a firefighter to a lorry driver due to his pain in his knees from osteoarthritis. Would you refer this patient via the 2-week wait pathway? I'll give you guys a few seconds to have a think. Right. So we've got some split responses here, and 60% of you have said, around 60% of you have said no, and a few, around 30 have said yes. So to be honest, I think this is a kind of a grey area as to whether or not we would refer him. I personally put not refer because his symptoms are most likely explained by him switching jobs from a very kind of active job to a more sedentary job because of his OA. Whereas I wouldn't say that people are wrong for referring him as well on the basis that he's got a change in bowel habit. Yeah, I think I would say in this question, this might be a trick question, but I'd say both answers are correct. Judging clinically, I would say he's a bit more on a low risk side of things, but I wouldn't say that one is wrong for referring him to the 2-week wait pathway as well. All done, everyone? How would you manage this patient is my second question. I don't think we have time to kind of go through in detail and get people's responses, but so really I think you would really kind of just advise him for his constipation, which can be confused with the change in bowel habit, and you would probably safety net him as well, which I didn't put here, but just making him aware that if this kind of constipation doesn't resolve, with lifestyle advice to come back, and we should refer him as well. Everyone happy? Any questions? Oh, somebody's answered the question on the chat. Well done. All right, I've got another case for referring or not referring. I was not the, yeah, so people have put kind of good responses as well on the Menti. I'll start the Menti quiz for the next case, which is a 41-year-old woman attending the GP for a routine appointment. Besides from a 2-week history of generalized abdo pain, she is fit and well, not on any medications, and she's recently lost a stone in weight. Would you refer this patient for a suspected colorectal cancer? We're running a bit short on time, so I'll move on. So in short, yes, you refer her because she's got kind of unexplained symptoms, and she's also got weight loss, which is kind of a red flag in cancer. So here are some referral criteria for suspected kind of lower GI cancer. So I think some emphasis should be made on, should make the question of whether one should make a referral or should consider referral. So a 2-week wait should be made in these kind of situations. I won't read them out, but I think all of you can have a read, go on nice and have a read of it in your own time, because we're running a bit short. And a 2-week wait referral should be considered if any kind of these symptoms are present. I think it's important to take into context the clinical picture as well of the patient, and kind of patient wishes as well, how worried they are about kind of their own body. That should be taken into account when considering. I'll leave that for your own time. This is really important, I'd say, to know for final exams. So I definitely say to put some kind of work into remembering these criteria. Got a last question for you all, which is the NHS bowel screening program. It's about kind of whether or not we should screen a patient for bowel cancer. So we've got a 62-year-old female. Her previous FIT test was normal. Would you screen this patient or not, in line with the current bowel screening program in England? If you're not from England, please feel free to ignore this question. It might not be relevant, but yeah. So I'll move on, as we're running short of time. So in this case, we would screen the patient. So in the NHS bowel screening program, it's in England, but we will screen everyone from the age of 60 to 74. So every 2 years. So if they have an odd number or they've missed one, then you can screen them every 2 years. So the patients have the call to request a FIT test, a FIT kit, which tests for an immunochemical in your poo, and it will use antibodies to detect hemoglobin, and will be informed if their results it's positive or negative. So if it's positive, patients will be invited for colonoscopy. And if the FIT test is negative, then you repeat them in 2 years, like a screening test, until they turn 74. So that's about it for today. Thank you very much for coming. I'll just do kind of brief summary to highlight kind of important concepts in lower GI, really. So some of the higher concepts are colorectal cancer, referral criteria, clinical features. These you really, really must know before you go into an exam. Diagnosing and managing emergencies, such as bowel obstruction and appendicitis, and also mesenteric ischemia. For OSCEs wise, I think it would be kind of good to brush up on an approach to acute abdomen. So how would you take a history? How would you examine? How would you investigate? And kind of how would you do an HV assessment to kind of primitively kind of manage the acutely unwell patient, as well as to lower GI bleeding, kind of upper GI bleeding as well, which we'll talk about in the next lecture. So some top decile concepts will be the genetics that we covered in the last top decile question, something to think about if you're aiming high. Otherwise, thank you very much for coming. Before you guys go, I'd like to ask all of you to fill in a feedback form. If that's okay, I will send in the link in the chat in a second. If there are any questions as well, feel free to pop in the chat. I'll answer them. yeah. There's someone who asked what was the answer for the last question about the screening. So the answer for the last question would be to screen her because she's in the age range for the screening program. If that's all right. So I'm just going to send the feedback form in the chat. If you guys could please kind of spare 2 minutes to fill it in and give some feedback to improve the sessions. And before you guys all go, there's a next session in upper GI surgery, which will be covering kind of SBAs as well, on the 18th, which is in 3 weeks' time. So please do look out for it. Thank you very much for coming, and I hope you guys have a great evening. Hope to see you next time.
Thank you, Adan.
Thank you.
Thank you all for coming. Have a lovely evening. Take care. Bye-bye.
Yeah, take care.